I think there are a couple reasons why emergency medicine is the perfect place for me. But I think when I was in medical school, I just liked it because you got to know a little bit about everything. When I thought about subspecialization or specialization, I thought, well, if I do cardiology, then I don't know anything about the kidneys, or if I do orthopedics, I don't know enough about plastic surgery. I mean, there were just so many different options.
Liz sort of thrives in the chaos, if you will. She likes it when it's busier. She can very rapidly diagnose a patient almost at the bedside.
When people come into the emergency department, they are scared. They think that something is really, really wrong with them.
We in the emergency department have a fairly large challenge, and I think Liz is excellently successful at doing this, is to gain the patient's trust within the first 10, 15, 20 seconds.
A lot of people think that in the emergency department you don't get to develop longitudinal relationships with patients. It's a different type of relationship than, say, an oncologist who sees the patient over and over again. But the connection that you make with people can be immediate.
Stick out your tongue. That's my favorite part of the exam. All right.
She's very active in the emergency department, takes on lots of leadership roles.
In 2009, I started a program hiring physician assistants for the emergency department.
Liz has taken it upon herself to take the PA group under her wing in terms of teaching.
I last year took over as medical director for the nurse practitioners as well, who run our observation unit. So it's basically like having my own residency that I take care of. I see my job as trying to make them the best clinicians that they can be.
She's not just doing the routine. She's always thinking, how can we do this better? How can we make this simpler? How can we help our patients more?
I think my real problem is that I can't keep my mouth shut. And so I kept going to my chair with ideas. Can we try this? Can we try this? Can we try that? And finally he said, well, if you're going to just keep talking about it, you might as well do something formal. So I joined our quality and safety committee.
Quality and safety initiatives start at the very top from the board of trustees of the hospital and the PO and trickle down to every nurse, every patient care assistant, every transporter.
I have the best set of colleagues I could ever imagine. Everybody goes out of their way to really help each other out.
She brings a different perspective often to the various meetings that we sit in, being vocal and advocate for both the PA group and the patients themselves.
I find that exceedingly personally satisfying, that there's at least some small part of the world that I can try and make more efficient. I think there are always tough shifts where patients may be angry or things didn't go as smoothly as you wanted, and trying to always see the positive impact that you had on that same shift is helpful to try and go home with a positive attitude. How are you feeling right now?
I feel better now.
Do you think the nitro made it better?
Can I be honest? I think just the whole crew, the people, the laughter, the talking. I feel more relaxed.
That's good. Okay, we'll take it. I am really, really lucky that I have such a wonderful husband who helps a lot at home. He gets the kids ready for school every morning, he gets their lunches ready, and I couldn't do my job if I didn't have someone who is as helpful as he is. I love my job. I can't imagine doing anything else. I am in a position when people are their most vulnerable and most scared to make a connection, make them feel safe, and possibly change their lives.
Women's Health Associates is a practice that was set up in 1985 as the first multidisciplinary primary care practice for women in an academic medical center at its time. It was also designed with the needs of the physicians and the clinicians in mind, to provide a setting where women physicians could spend their whole careers going through all of the ups and downs of taking care of other people and still do a fabulous job.
I've been seeing Dr. Carlson for at least 15 years, and maybe even almost 20. I think the uniqueness of our relationship has a lot to do with the longevity, because we know each other as well as we do.
I can look back at the length of the relationships that I've had with patients, and also the depth of relationships that I've been able to develop with patients. And I find that such a wonderful thing, both personally, but also I think clinically. It makes me such a better doctor. It has joys, but it also has a ton of challenges as well, because patients can really be difficult. If we want to keep physicians going over the long term in primary care, we have to find some way to provide them the support and the tools that they need to process some of the feelings that come up in the course of patient care. We've established in women's health, and we've now established in general medicine, a ballot group, which is a form of group peer supervision to talk about cases that we take home with us at night, cases that we find challenging. Encouraging, modeling, creating a culture that says, you know what, self-care is important. First, put on your oxygen mask before you try to help the next person.
It's really great to have someone like her as a role model and as a mentor. She tends to ask more questions than give, declarative statements or advice, and really helps find my answers through the answers I'm giving her.
It gives me a lot of joy to be able to see young people who learn something from what I have to teach. To be able to share your experience and your mistakes and your wisdom, helping young people coming up do things better than you did.
When I had my hip replaced, Dr. Carlson came over to visit me here at Mass General and sat on the bed and had such a it was so nice to see her when I was in that situation.
It does mean something to people when they have a long-term relationship with a physician. It means a lot. And sometimes we don't even realize how much it means just by being there for them. To me, that is also the joy of primary care.
This morning we're taking care of a patient. Her illness really started 2 years ago when she was diagnosed with this sarcoma. Dr. Raskin was her orthopedic oncologist who ended up resecting this giant tumor in her leg. Subsequently, Dr. Cote took care of her, administering pretty intensive chemotherapy regimen. 2 years later, she has a small nodule in her left upper lobe that is suspicious for an osteosarcoma metastasis. And our approach is going to be a video-assisted thoracic surgery, which is a minimally invasive approach to removing lung nodules. They give you a little something?
No allergies, antibiotics.
One of the great things about working in thoracic anesthesia, working with our residents, is the opportunity to teach them, as well as the opportunity to learn from them.
This is Uma. She's our first-year fellow in cardiothoracic surgery. She trained in general surgery here as well, so she's been here for a while.
I'm going to be assisting Dr. Muniappan in resecting this part of the lung.
She had the precursor there 2 years ago. And then she had what was unusual about her care. Our trainees are at a different phase of their career as a physician. And every case is an opportunity to teach.
We're really working as a team. We work very closely with the surgeons. The things that we do directly impact them and vice versa.
Kelly is a surgical technologist.
I'm here to assist Ashok and try to pass him the right equipment at the right time, anticipate his next moves.
There are cases where we can get into significant bleeding, where things are not easy to dissect out, and you really need somebody like Kelly at your side. Rosalie and Martin, right?
Yeah.
We've done a wedge of the left upper lobe. Heretofore, we don't know what this lesion is.
I'm writing down the dimensions of the specimen, and I am seeing how close the lesion is to the margin.
I'm Jeck. I'm one of the pathology residents. I'm just gonna open up this lung specimen, and I'll take a section of it, and then Carol over here will take that frozen section. She'll cut a slide, stain it really quickly, and then one of our pathologists will be here to take a look at the histology of the lesion and presumably tell the surgeon what it is. It's very well circumscribed grossly.
Dr. Creighton has just informed us that the nodule is likely an osteosarcoma. The good news is that it's a negative margin, a good margin, so we're optimistic that we've removed all evident disease. We're going to conclude the operation now, close her incisions, and get her to the recovery room. Osteosarcoma. Just in a matter of being in the hospital for 2 hours, Miss Mentor's really interacted with a huge cast of people, nurses, residents, attendings, pathology, and as you'll see, it's going to continue.
Our job basically is to check patient families in when they come in and then try to keep them informed.
And this gentleman is one of the ones who we can always count on to come down. Not all surgeons do, but we can always count on him to come down after every procedure.
When the surgeon comes down, I think it's more personal to the family and it means more to them.
Told us everything, like everything we needed to know, everywhere we need to go, what room she would eventually end up in, what room she's in now.
Emphasize that it's a tiny operation. She needed the spot removed. It was important. And we accomplished that in a very straightforward fashion. So Ms. Mentor spent the standard time in our recovery room, got her pain controlled.
We work really hard up here to make sure everyone's up out of bed. We kind of call it secret boot camp, where everyone might not like us right in the moment, but we get them up, out. How do you feel about going for a walk? Already, I know. We're up out of bed, it's the first day, but if you want to get out of here, we got to get up and move so that your lungs inflate, we can get you off that oxygen.
Over the past 2 nights, Vicky did excellent. This morning we're planning on discharging her.
Her chest tube was removed yesterday, feeling much more comfortable as we predict after the tube comes out. I've already been called by my residents this morning. She's pretty much ready to go. Hey, Miss Mentor.
Hi.
Good morning.
How are you?
Good. You?
I'm doing great. Ready to go home.
Yeah. I can remember a patient's family member recently telling me, I don't know how you do this. I certainly get it that not everybody would want to be in this sort of situation where you're confronting cancer, you're confronting complications, you're confronting death. On the other hand is the knowledge that I do know I make a difference. I do help people, I do cure cancer. And I always take a secret joy in those moments. You did great, okay?
Thank you.
All right.
Thank you for your help. Really appreciate it.
You did good, okay?
I'm going home.
It is really important that without becoming self-centered, which can be a risk among some of us arrogant docs, that we understand that in order to do well for our patients, we need to do well for ourselves.
When I think of who I am, physician comes up right at the top along with mother and wife. But I think it's maintaining a balance between those and a balance between keeping yourself sane while you're doing all of those other things.
We need to know who we are as people, and we need to be able to bring our best selves into our encounter with the patient.
It all comes back to seeing patients do well and trying to meet the challenges that they're facing. And I think that's what sustains me.